Good afternoon, and thank you for joining us. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School. Today, there are over 250 registrants for the session Engaging Minoritized Communities in Research. Individuals such as physicians, faculty, students, trainees, social workers, administrators from across multiple schools and community organizations. Today's webinar is sponsored by the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School, DICP. And the mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, and identify and train leaders in academic medicine and health policy, and provide programs that address crucial pipeline issues. About our Equity and Social Justice series, today's webinar is offered through the DICP initiative, this DICP Equity Social Justice Initiative, and this is the first ESJ webinar in the current academic year. In the fall of 2016, a planning committee comprised of faculty, staff, and students representing our Harvard community discussed the establishment of an ESJ series to address health disparities, social determinants of health, leadership in health systems, health policy, and other areas affecting vulnerable populations. Since 2016, an average of 10 to 12 programs have been provided annually and in collaboration with our Harvard Medical School affiliated institutions. These events focus on 4 areas. First, history and context. Second, culture and environment. 3, health disparities, and 4, leadership and skill development. This year, the ESJ lecture series tackles health issues that often impact disadvantaged and vulnerable populations. Our conversations and speakers will address not just defining a disparity, but will also discuss interventions on a community, hospital, and policy level to address those inequities. Now, a few housekeeping notes as we begin today's session. The chat is not available. Your microphones will be muted, and you should use the Q&A to post questions to panelists. The webinar is recorded and will be posted on our DICP website in the future. And now it's my pleasure to introduce Dr. Alden Landry, who is an emergency medicine physician at Beth Israel Deaconess Medical Center and is the founder of Motivating Pathways, Inc. He's an assistant professor of emergency medicine at Harvard Medical School and assistant dean in the Office for Diversity, Inclusion, and Community Partnership, here also at Harvard. And now it's my pleasure to turn this over to Dr. Landry.
Thank you, Dr. Reed, for that introduction, and thank you all to joining us for our Equity and Social Justice Lecture Series, our first conversation of the year. We're excited to be here to have this conversation and to have a conversation that is a topic that I know is actually in the news a lot, and there are some great articles being published within the past few days, even having discussions around the engagement of communities that have historically been abused or marginalized in research settings. And so with that, we're going to have this conversation over the next hour with 2 amazing speakers who are going to bring their talent and expertise to the floor and share with you their thoughts around how we can better engage minoritized communities in research. And I'm going to do a very brief introduction of both of our presenters, but I would encourage you to look them up, read their bios, and see all the amazing work that they do, and think about how you may potentially collaborate them for future endeavors. So first is Dr. Cheryl Clark. She's the Director of Health Equity Research and Intervention at the Center for Community Health and Health Equity at Brigham and Women's Hospital. Next is Krystal Tsosie. She is a PhD candidate in genomics and health disparities at Vanderbilt University. And congratulations to you as an incoming faculty at Arizona State University. And although my introduction of them are brief, I would encourage you again to listen to the amazing words that they're going to share with us as we have this discussion and learn from their expertise. And so, Cheryl, I just want to turn to you first and really want to start with a broad conversation. Can you give us an overview of how research has approached engaging minority communities in the past?
Absolutely. First, I want to thank you, Dr. Landry, Dr. Reed, and Dr. Tsosie for joining me on the panel. Fantastic that you have arranged this conversation. It's one of the critical issues I think that we really need to grapple with in academic medical centers, and as we think about what it means to advance science in a way that promotes health. And as I think about the topic, how do we, what does research typically look like, particularly for people of color, for African Americans, for Indigenous populations? There is a long history that is embedded in structural racism and structural inequities. It's also important to really think about the way that research is financed and structured. When we are our best selves, right? Health research is really supposed to be about making us better. We're supposed to put findings into place that help to cure disease. And the question has always been how and for whom. And I think the problem here that we're grappling with is exclusion of populations, of investigators, et cetera, from this enterprise. A lot of the research that's funded in the United States sort of happens in buckets. In terms of sort of drug development, the clinical trial sort of infrastructure is chiefly funded through the private sector, where there an industry where there isn't a lot of oversight and mandate. The Food and Drug Administration certainly and has has standards around some of these issues, but they're not mandates. And there's a smaller portion of that research that is funded through the National Institutes of Health, which does have a mandate and has had standards for greater levels of inclusion. And then there's foundations which have their own sort of standards for how that work gets done. So if you look at this broader infrastructure for how research is funded, there's not a lot of oversight, not a lot of teeth that make it a requirement that the investments that are placed into research enterprises should at all require us to ask the kinds of questions that are important to multiple communities, to include communities in research. And so what you wind up having are a lot of restrictions in terms of who can enter, a study, restrictive clinical trial, standards. You have research questions that may or may not engage the critical issues that actually influence the health of diverse populations, including the social determinants of health. And you also have an industry where the researchers who conduct the work tend not to get the funding. The NIH, National Institutes of Health, conducted an analysis and was able to provide some data that about 2% of all R01s go to investigators who identify as African American, and 3% go to those who identify as being Hispanic, Latino, or Latina. And all the rest of the funding go to other populations, including those who may identify as Asian, which is a smaller population and a complicated bucket to look at. So as we try to understand, what this looks like, we have a lot to do, both to make sure that we think critically about how we are incentivizing and investing in research, what the structures ought to be to make sure that the kinds of research that's done really reflects the needs of our populations, and that the investigators who do that work are also diverse. So that's kind of a broad entry to the topic, but some of the concerns that we need to be mindful of.
And I really appreciate how you laid out the research complex that we are all a part of and we benefit from, and some benefit more than others. And I think it's really important to just lay it out plain so we can all have really the same sort of starting space. And as we move forward and continue in this conversation and think about interventions and think about solutions, we know where this is coming from. So thank you for that explanation. I want to turn to you, Krystal. We always talk about mistrust in research. And I think for a lot of people, they refer to the Tuskegee syphilis study as if that is the etiology of the lack of trust in all of the healthcare system. In the community work that you have done, what are the examples of mistrust in research of the healthcare system that your populations that you work with are often concerned about? And additionally, how can we think a little bit more broadly about the roots of this mistrust?
First of all, yeah, for the kind invite to be on this excellent panel, I just want to echo, I am in complete agreement with everything that Dr. Clark just mentioned, and I'm just nodding along and writing notes furiously, completely echoing all of her excellent statements. But I think you're right. If you're taking city ethical training, CITI ethical training, until like a few years ago, when you took the biomedical research ethic component modules, it basically felt like all of research up until Tuskegee was unethical. Then, oh boy, you know, now we have had this great reckoning of how research should be done on human subjects in an ethical manner. And now we have the Belmont Report, and now we have the Common Rule, and now we have all of these legislative and federal regulations on research. And yay us, you know, research is now ethical. No. Since the 70s, I mean, including the 70s, and since then, there has been, you know, time and time again, there has been news about how research harms continue to be perpetrated onto our communities. One thing that's not really mentioned is in the 60s and 70s, we had Nixon had the Family Planning Act, which forcibly sterilized Indigenous women who were seeking care through the Indian Health Services, which is by treaty, you know, those health services need to be provided to us, and they would go in for routine care and then come out effectively sterilized. This was a next generation of the eugenics movement that we had seen. And then since then, you know, even within the past 20 decades, we have a lot of research harms on the Indigenous communities. We have the landmark lawsuit in which a tribal nation at the base of the Grand Canyon, the Havasupai tribe, sued Arizona State University researchers and could have bankrupted the entire Arizona Board of Regents, which governs the 3 state universities in the state of Arizona, for violations of mistrust or violations of trust related to use of their data. And it's interesting because the ethical norm at that time in the 20s was effectively like this a sense of ownership that researchers had a right to samples, such that a researcher by the name of Dr. Rick Ward, he took samples from Indigenous peoples in British Columbia across international borders twice without the consent of communities, and was originally meant to study things like rheumatoid arthritis, but ended up studying on several other publications. I think he had over 60 publications from this community's samples that was unconsented. And he never faced any ramifications. The dude died, but you know, that's also another landmark case that we really have to think about. And when we think about like that sense of ownership of samples, and you know, issues related to broad consenting, those issues are still pervasive today. When we think about data and open data, and there's a rush for harmonizing data across open data sets, what did we do? We disentangled the human element and the initial consent process. And now any data that's banked and supposedly de-identified is considered secondary data. I'm sorry, there are several papers that show that you can bioinformatically re-identify biological data. And particularly with genomic data, which is my data of interest, data has the ability to re-identify groups, not just peoples, but everyone that that individual is biologically related to. So when you think about small populations like Indigenous communities, you have a huge risk for genomic racial profiling. And when you're starting to disentangle individual and community rights to that data, you're starting to become into this open market for the potential of bioprospecting and biocommercialization and patenting. And I really want to go into a huge tangent about the the entanglement of money with research. But I really want to just question, why is it such a dirty secret that research is funded with money? And, you know, we have to ask ourselves, is it because we're not supposed to question private interests in public data? And also, is there just an assumption as to who owns the data or who should have access to that data? Just one last point. You know, earlier this year in April, there were a series of articles that came out questioning what has been the last 20 years since the completion of the Human Genome Project, and what has it actually borne fruit in the way that we think. And in Nature, somebody wrote something to the effect of, the broken promise to researchers is that the data is not openly available. I'm sorry, but the broken promise is to communities that provided that data. You know, there has been, there's a New York Times article that went back to Indigenous peoples in the Amazon area, and they asked them, you know, you gave your blood samples, what was promised to you? And the tribal community members said, we were promised medicine to prevent disease. We were promised health interventions. And then the reporter asked the community, well, what did you get? Nothing. They're still waiting. That was literally blood money and blood for money, and they still haven't received those benefits. And I always ask researchers, you know, when you're going into communities and giving this promise that precision medicine and genomic medicine is going to bear results, like, what timeline are you giving? And, you know, most of the time researchers say, oh, somewhere down the line, this might actually benefit people. And then I ask, you know, don't you think that's overpromising on something you cannot deliver? And I've had one or more researchers disappointingly state to me that that's not our domain. Our domain is just the research question. That is sad. And we have to fundamentally question what our role is, especially if we're going to talk about engaging communities in research.
Well, thank you for that answer. And I just want to bring you in, Cheryl. Did you have something that you wanted to add to that?
Absolutely. I just want to second and just completely elevate and underscore what Dr. Tsosie is saying here. And to also just pick up on the point that you're making around trustworthiness. The way that you have described this and framed this is just powerful. You know, that we talk a lot about trust in research. And I want to also add, you know, the experience of the All of Us research program. I'm one of the principal investigators of community engagement in that program. And we have had to think through, you know, what the right response is. You know, the issue of who owns your information, you know, what are the promises? What do we expect in terms of what we donate? I couldn't, you know, we can't have this conversation also without remembering the story of Henrietta Lacks and how the HeLa cell line was developed very much, you know, without the consent and respect of a woman and her, and, you know, her personhood. And the Lacks family, you know, became a partner to really kind of confront this issue within the All of Us research program, and to really make sure, you know, that we talk about it, you know, that we have this open conversation about not mistrust, but trustworthiness, and how we as a research enterprise need to put that into place. And the only other comment that I wanted to make, just completely embracing everything and excited about what Dr. Tsosie has just laid out perfectly. It also brings up the importance of diversity in research. I cannot tell you how excited that I was to hear that Dr. Charles Rotimi will be heading up the Institute for Genomics Research for the NIH. As we think about just what inclusive research looks like, Dr. Rotimi was responsible for the African sort of genome being integrated into the HapMap so that we can start to ask those questions. But timeline, you know, how do we think about it? You know, it's always sort of, you know, at some point, and we understand that research takes time, but there are other parts of the research that we can think about that have shorter time frames. You know, for example, during COVID, one of the issues that came up for us was the fact that we didn't really, at the beginning, like in March, have any sense of what to do, around COVID. There was so much disinformation. You could use your research infrastructure, to kind of, answer a bunch of questions, and we need to do that. We're curious, and to write papers, but you can also use your infrastructure to care about people. One of the things that we did was to call the 20,000 people who were a part of our program to ask them how they were doing, to see if they were okay, and to provide information around social determinants of health and other things. And so just really excited, to hear Dr. Tsosie's comments around sovereignty, trustworthiness, and what is it that we are really doing when we say that we're making, research for the benefit of people. How are we putting that into practice? I'm just really excited to hear the way that you are laying that out and making us confront that. So I appreciate your comments.
And I just want to say thank you both for really reframing the discussion from mistrust to trustworthiness. I think that's something that we really need to be thinking about. And, I'm going to stick with you, Cheryl, just to continue your flow of thought. When we talk about better engaging research communities, like you just mentioned, with calling communities and giving advice, giving feedback, helping them through tough times, I think that's something we really need to talk about a little bit more. So how do we better engage communities in research? Specifically, how do we identify topics that individual communities are concerned about? Or maybe how do we explain our research and why it's important to those communities that we're trying to engage?
So it's interesting. And I'm going to say that I don't remember the movie that this came from, but I think it did come from a movie. But if you sort of you'll build something, maybe people will come, if you invite them. And if you work together and partner and everybody builds it together, they're already there. And it sort of looks like what people need. Oh yeah, okay, I knew that it was a movie. So that whole model around sort of what we call community-based participatory research, it's an approach. It's not necessarily a method. It doesn't mean that you have to do a particular kind of science. You can do basic biomedical research. You can do genomics research, anything that you want, and invite people in. And partner with people to, that's the one, the Field of Dreams. I see it kind of come up from the chat. You can use approaches and center the needs of diverse populations from the very start of the research, including how the research is funded, and making sure that you apply, if you're an investigator, to multiple sources of of funding, so that you can conduct the science and the scientific research, but also provide the service, the service that are needed by the partners that you're working with. You can think about how the funding gets distributed. Many National Institutes of Health grants, as we know, provide funding, for the project and the work that's being done, the science, but also something called a facilities cost or an indirect cost, so that funding helps to pay to keep the lights on and that sort of thing. And often in an academic medical center, when you want to engage communities, you invite people to come and sit on your advisory board, or you invite them in to sort of give their opinions. But not only do we often not remunerate people appropriately for that time, but we also don't provide that facilities cost, so that we build infrastructure and we build capacity within the organizations and with the communities that we'd like to do this work. I am really, I think, excited about some models across the country for doing this well. Keith Norris, who's been at the University of Los Angeles, came up with the concept of community-placed participatory research, where the focus of that research is really investment in local communities and making sure that the research reveals the scientific question, but it also has these other externalities where the infrastructure for conducting the research really does invest in the local communities, and that kind of structural inequity is addressed directly in the way that the research is funded. And I think that there is going to be a new initiative that applies some of those techniques to look at a specific kind of research in AI and sort of community engagement called Aim Ahead out of the National Institutes of Health. So definitely let's keep our eyes out for that and how Dr. Norris and others will conduct that research. But I think fundamentally, when we think about what it means to engage participants in research, we need to be there physically, financially, authentically, in partnership with organizations and communities when we don't want to ask scientific questions so that we build those relationships. We need to practically, conduct either needs assessments or just listen and have community investigators help us to define the problems. What are the problems or the opportunities that that we ought to be studying and that we'd like to address and direct resources toward? We need to fund the work appropriately, including community investment. And we also need to think about dissemination, and I know we can get into that. There are some organizations that are national organizations that help us to do that. One is Community Campus Partnerships for Health, which provides infrastructure and strategies for how to do this respectfully from an academic perspective. And the Patient-Centered Outcomes Research Institute is now led by Nikayla Cook. And PCORI, as it is called, funds infrastructure grants to allow communities to come together to define their priorities. And so there are strategies for doing this. It really is about values and making sure that we put that into place.
Thank you for that 360 answer on that question. I really appreciate how you dove into that. And we're going to talk more about indirects and building in the community and making sure that research is centered in the community as opposed to taking from the community. Krystal, just along that, continue along this theme, thinking about the slogan, "No research on us without us." What are your thoughts on that slogan, and how can we sort of really make sure that that is something that we ingrain into research?
So the English version that you just mentioned actually comes out of disability activism community. So I want to make sure that we highlight and ensure that we're not co-opting that term. Just like also I want to highlight the etiology of community-based participatory research and participatory action research. These are methodologies that are actually in environmental justice movement in the 70s, and it's only been very recently applied to biological and biomedical science. And I and other Indigenous geneticists have co-authored a paper on ethical engagement and how to do that successfully in Indigenous communities, which is applying those principles of CBPR to all the phases of research. But I also want to give credence and due respect to Dr. Eddie Brown, or I think is retired now from Arizona State University. He was originally in the American Indian Studies Department, and he coined the term tribally driven research in the late 90s. And I love this term because at the time that he coined it, it was largely a theoretical model because at the time we didn't have a large amount of research trained individuals and academics that were empowered by these colonized institutions to be able to do this type of research. And this research has typically been historically done in a unidirectional manner. And I really want to highlight, and I really appreciate the efforts of the NSF for really highlighting and acknowledging that these different levels of expertise are not just at the PhD and MD level, that the NSF has really acknowledged that researchers can be PIs with master's degrees, especially within tribal colleges and universities, which is where a huge number of American Indian students are being trained and are being trained to lead in fields related to science and also data science. So I really want to just highlight that it's now been very recently that we've been able to have a trained cohort or a bolus of Indigenous scientists and data scientists to be able to take the helm of this research. And, it's not just us that's doing it, it's community members and tribal leaders. So we're really thinking about creating institutions and leveraging our tribal sovereignties across whatever that might mean. And these are tribal sovereignties that are not colonial and extrinsically defined, but are defined by our communities to be able to take the helm of research for ourselves. So I would be remiss if I didn't mention my own nonprofit, the Native BioData Consortium, which is the first Indigenous-led biological and data repository led by some of the now nation's renowned Indigenous scientists and leaders. And we have community advisory board and board advisors and everything. And we want to really ensure that the research is on questions that interest the community, because community members, we have always known to be true, because they have lived in their lands and have had their ways of living for it since time immemorial, they're going to best inform the types of research questions that affect them better than outsiders can. So really our whole model of engagement is uplifting their levels of expertise and ensuring that the research benefits them. And to echo the point by Dr. Clark, we're looking beyond just genetics and clinical phenotyping that can be found in medical records. We're looking at other contributors to health, be it environmental or cultural, but really structural barriers due to health. When we think about, the pandemic, COVID-19 disproportionately impacted tribal communities like my own, the Navajo Nation, at the very beginning. But that wasn't necessarily due to biological differences between groups. It was due to structural differences. The fact that my people had to drive sometimes several hours one way just to get to a preventative healthcare physician, or the fact that our water rights have been usurped from the ground beneath us, making preventative measures like hand washing a public health concern. We have to think about these factors as it relates to health and not just reduce everything to biology. And that, ties into a number of excellent ongoing conversations that are ongoing related to perhaps the over-racialization and biologization of race and racial differences. And again, we have to point back to those discussions originated in social sciences and often from scholars of color. And we have to make sure that those messages are being uplifted, as well as those people who originally brought those to our ways of thinking.
Thank you. And Cheryl, one of the big issues, and Krystal alluded to this about accessing care, but flipping this to make sure we're talking about research, one of the big issues is in this space is the emphasis on patients and communities coming to us in the major academic centers to participate in research. How do we flip that model where the emphasis is where the research happens in the community instead of in the hospital?
So it's interesting as I think about some of the institutions that gather and sort of are most highly funded in the United States. Many of them are actually located in communities of color. For example, I practice medicine and conduct research at the Brigham and Women's Hospital, which is an affiliate of Harvard Medical School, which is right in the heart of Mission Hill, Roxbury. As I think about Johns Hopkins, another sort of well-funded institution right in the middle of Baltimore. And so as I think about what it means to be located and to sort of have communities come to the academy, a lot of the distance to some extent is social, in addition to being sort of geographic. And it's the idea that people don't feel welcome, don't feel safe. There's a history of that's both documented and not, of how people feel treated when they come into our academies and institutions for care, which then translates into the way people feel about participating with you or with us in research. As I sort of, think about these models, part of what we have to do is to create the environments of trustworthiness. We often talk about Tuskegee as an event, as a signifier, not because most people even necessarily know all the details about what happened during the study, but because it was documented. It is the one thing that you can't deny, that you can sort of hold on to express this feeling of experience of structural racism, feeling discriminated against. When people sort of say, like, oh, don't forget about Tuskegee, it isn't always necessarily about the study. It's about that experience. And we often don't acknowledge that this is not a history, it's a lived experience, but one that isn't always documented so that we can't always talk about it. So I think when we talk about what it looks like to, to bring research and to have it in community settings, we have to think about that social distance, about how do we eliminate these power inequities? How do we eliminate the kind of infrastructure that's social, that keeps us from owning, our own research, that keeps communities from having the infrastructure and investment to drive their own agenda, which often can have a scientific component. And how do we also think about the actions that sort of come from that? I know that we're going to talk a little bit about some examples of what this kind of activism can look like, and I'll give you an example then. But I want us to really focus on what that social distance looks like when we think about what it means to bring research to communities.
Krystal, I want to turn to you. As we think about resources that come from grants, and Cheryl alluded to this earlier, oftentimes those funds and those resources don't go back into the community. Those indirect funds are not used in the community, but in the academic centers. How do we rethink the flow of funds? How do we embed resources in the community that are sustainable?
Oh, that's a great question. If I had a nickel for every time the NIH or NSF comes out with a large grant related to increased inclusion of diverse communities and populations, and if I had a nickel for every time, it feels like, I know, well-meaning, but historically white researchers start, knocking on Indigenous researchers' doors, asking for letters of support and collaboration, but, not really offering much power and inclusion in the actual research itself. I'd have a lot of nickels. We have to think carefully, because you're right, those research funds should be directed to the communities that are providing the data and are the ones that are disproportionately at risk, because they're, risking their people's inclusion in their data, in my case, DNA, for these studies, but not getting the benefits out of it. I mean, that's already like a disproportionate power dynamic there. But if these asks are not done correctly, that can be a form of exploitation, financially and also professionally. It is one thing to just uplift community members as co-PIs, but we need to think about doing that beyond just doing it like on name, by name, on paper. We have to really think about how we're actually training community members to take the helm of the research, especially if they're the ones that are on the ground locally doing the community work. One of the unfortunate things that can happen if we just define expertise by terminal degree status, you get a lot of senior PIs that are by name on a grant or on a project, but the actual work is done by tribal community members. And that is not a good scenario, because, the benefits are unidirectional and at the expense of community members' effort. Another thing is, like, when researchers ask for a letter of support or collaboration, if the grant gets funded, not just disappearing right afterwards, really ensuring that you're following up on those promises. Another thing is that it feels like whenever Indigenous peoples are asked to be a part of these things, our efforts are usually just limited to education. That seems like it's playing it safe. If we're going to talk about, increasing equitable partnerships and relationships in their research, then we need to be in the actual research process. At the phase of nothing about us without us means also we need to have skin in the game when it comes to the collection of data and also the results dissemination. We really just need to think about how grants are thinking about power dynamics in the research. I just had a paper that launched this morning that talked about how in this climate of the single IRB mandate, in which one university's IRB is the IRB of record, it's meant to streamline research, but what can happen is larger institutions, larger universities might have institutional policies that preempt their own IRBs over external IRBs. So, this is a form of usurping tribal sovereignties if they don't even recognize that tribes have their own research regulatory processes in place. And, that affects data sharing agreements. Data sharing agreements are huge. These are legal documents that also have huge ramifications about intellectual property and future data ownership and stewardship. And if those partnerships and agreements are unilaterally favoring the universities, then you're also usurping future power from tribes as well. So we can't just think about, if we're going to think about research and we're going to think about the commodification of research, we also need to think about how are we ensuring that this data is also going to enrich local STEM capacities and economies. And that is an area of research that I'm really interested in pursuing, because when we're talking about data, we're talking about money, we're talking about, what it actually means to advance technologies for our communities.
Thank you for that answer. And just a quick note, I want to be prepared to answer a couple questions from the audience. So for those who are viewing this webinar, please feel free to use the Q&A function to hopefully we'll have an opportunity to take a couple questions for our panelists. Cheryl, once the research is completed, what do we need to do to better refer this information back to the community? How do we make sure that the patients and the communities involved in studies actually benefit from the data once the outcomes are produced?
I think that I'm going to answer that question in a couple of ways. I think fundamentally, the way that Dr. Tsosie has talked about this, when you own your data and you own the information, then you have it. And so I think all the principles that Dr. Tsosie just mentioned, about, how do we think about really respecting and putting processes in place so that communities own their own information. And I'll give you an example of what that looks like in environmental action. There's a classic case study that folks who are interested and who are scholars in community engagement look at, called We Act in New York. And so I'm going to try to tell this story. It's not my story, but I'm going to tell it a little bit. And it basically, it is the story of Northern Manhattan and Harlem, and how early on in the 80s, the diesel bus stations were disproportionately, talking about toxic and environmental racism, stationed in Harlem as opposed to all the other boroughs. And people knew that this was going on. This was something that was widely known, but no one sort of studied it. The community organization We Act partnered with the local university to study this in a formal way, and outfitted the local teenagers and youth with backpacks to do air quality monitoring and to look at this. And they wound up finding that the air quality in those locations were multiple times the air quality standards set by the EPA. And the data was done in partnership and owned by both the Academic Center and We Act. And so they were able to do joint advocacy together, writing letters and doing public service and other announcements and getting the attention, so that the EPA actually came out and reproduced the study, and changes were made at the policy level to move those depots. And so that sort of shows you what a full circle research enterprise can do when the data and the information is co-owned and the work is collective. As I sort of think about other parts of the dissemination, we want to make sure that we're communicating well and using multiple channels to get information out. But we also want to make sure that the products of the research go to local communities.
the last case I'll sort of describe is COVID-19. A ton of research was done locally. Here in Boston, we had the Moderna trial for the vaccine. We had the Pfizer, sort of trial. All those things were set up. And we did a really an interesting job, I would say, of sort of getting the word out and asking people to participate. And quite frankly, when it was time to distribute the medications, we set up very large stadiums. The first one in Massachusetts was actually in Gillette. And it took a lot of advocacy to also set up not only large distribution sites in Roxbury and other locations, but also smaller sites with our local organizations to make sure that the drug gets disseminated into our communities. So we have a long way to go, but some of these principles are important. What I'm curious about, and I'll look forward to hearing both the audience questions and recommendations, is how we think about putting this into a framework and a structure so that it isn't just nice to do, but it's something that we need to do.
And, a question that often comes up in this as we talk about research is the workforce performing the research. And Krystal, there's a perpetual lack of diversity in the research workforce. How do we address this issue in a meaningful way? And if you have specific examples, success stories, please share those stories with us.
Sure. I think it's really important that when we're talking about training our next generation of leaders, that we provide a space for dissent, and dissenting voices. So we're not just training complicity. This is really important. If we want to train community advocates, then we need to ensure that we're listening to those voices that are not historically heard, and ensuring that we're not just training the next generation to repeat the same mistakes of the past. One thing that I think is really great, or actually a couple of different educational initiatives that I want to highlight, is one, the summer internship for Indigenous peoples in genomics. This is a consortium that started in the US to train Indigenous students and community leaders to think more critically about whether research can be beneficial in communities, and how, if it is going to be something that community members are interested in engaging with, how to do it ethically. And I think this is a really key point, is to state that, we have to ensure that communities are comfortable with the research. Too often I see the question framed in relation to tribes, like, how do we get tribes comfortable with research? Like, that's the wrong way to phrase that question. The question should be, how do we engage tribal communities if they want to participate? We have to acknowledge that trust, and going back full circle to the beginning of this conversation, trust doesn't happen within the timeline of researchers. Trust is something that's built and negotiated over time. And we don't have, we shouldn't have authority in directing those timelines, because we don't want these timelines to suit the researchers. We want it to suit the communities if they want to benefit from it. And, the same consortium has been really great and has expanded to other sites worldwide. And I feel like this has been responsible for training the existing Indigenous researchers that we have to call on right now. And I feel like that's why we have such a number of highly trained PhD level scientists in this realm. I also want to highlight Indigidata, which is an Indigenous data science education workshop that was launched by my organization, the Native BioData Consortium. These initiatives are, they come from the same number of research, same body of researchers, but they continue to grow and expand as we start thinking about data more holistically, and thinking about data beyond just arbitrary guidelines between what constitutes human or non-human DNA, which can change, by the way, depending on what country you're referring to, and then what constitutes legacy or secondary data or primary data, and all these other questions. And just think about, if we're going to think about global and more holistic models of health that include all of these things that relate to health, then we really should be learning more about these other disciplines. And I think it's just great to have, be able to have an Indigenous perspective on these things, and to ensure that we're not just taking from these knowledge holders and keepers, and ensuring that it gets built back into the future future researchers and students and leaders that are going to contribute back to their own communities. And I would love to talk more about that, but those are the two major things I'd love to highlight at the moment.
Thank you for sharing. And Cheryl, I want to go to you, and just thinking about your journey to where you are now as a researcher, clinician, scientist. Thinking about your journey, thinking about the things that you've seen, what should we be doing in order to really address this issue related to workforce diversity?
I couldn't agree more with what's been said, is that we really have to prioritize the knowledge of a broader base of people in society. This sort of, these like ontological questions about what knowledge is supposed to be. We just have to broaden our thinking about it, just how humbling, and how much we sort of, put our thinking around what science is, and, how often we have to sort of redo that. And now we're focusing, or at least embracing a bit more, this idea around social determinants of health. But fundamentally, we have to enlarge, what we think is worthy of funding, and who gets to sort of make that call. There's a paper in the journal Science that came out that showed that not only are African American and Black scientists, for example, less likely than other scientists to get funded from sort of government sources, but one of the primary reasons for that funding is topic. That people, that African Americans, Black and other researchers tend to care about health disparities or health inequities, and want to do that science and build that knowledge base. And that's not always something that's easy to get through what we call study section. And so in some ways, if we want to increase the diversity, of the workforce, then we have to fund, the work that is relevant to that workforce, and to the constituencies and places from where those workers come. So we have to just broaden our thinking around what knowledge creation is and what it looks like and who ought to be doing it. We also need to fund what the training looks like. The same sort of data description from Unite, which is the NIH, sort of infrastructure for thinking through structural racism and diversity, equity, and inclusion and research at NIH. Also published data on K awardees, these sort of mentored training grants, and showed the same, sort of disparities along the lines of race, ethnicity. And we haven't even gotten, to the point of being able to really describe well what this looks like on other axes of social identity, intersectional relationships around sexual orientation, gender identity, disability, other things that we, ought to be talking about. So there's, I think that's a theme of the night. We got a long way to go, but those are some of the issues that I would point to.
Yes, and and not to. I just want to say it's refreshing to hear both of your points, in that it's not about the need to make more researchers, but there are researchers already out there. They're just not supported. They're not funded. And because they're not supported, they're not funded, they're not able to do the work that they are passionate about that would actually make change. And so it's really refreshing to hear that, yes, we do need to do work in the pipeline, but we also need to support those who are there, and they often are under-supported. And Krystal, I want to go to you for maybe one final closing comment or a question, and that there's a researcher that's out there that's listening to this presentation. Is there a take-home point out of all the wonderful things that we've talked about, all of the great things that you all have said? Is there one sort of walk away point that you would love for them to take back and maybe bring it to their research committee meeting, their lab tomorrow when they're having their discussions?
Thanks. So DEI efforts, diversity, equity, inclusion efforts, are something that it's a great movement, but I think we forget the equity component. we are always rushing to increase diversity and inclusion in data sets, but honestly, those movements have been the same as other movements in the past, other large-scale diversity projects like the Human Genome Diversity Project, which has been lambasted by Indigenous communities for being extractive and exploitative. And so it's not necessarily about increasing diversity and inclusion in data sets, but increasing equity. So I just want to remind everyone that inclusion is not the same as equity. And if we misuse those terms, then what we're really doing is lip service or doing PR, public relations, and really cloaking what our true intentions might be.
Thank you. And I just want to close by saying I think this was an amazing discussion. Thank you to the both of you for taking time out of your busy schedules to be in this space. And I want to say thank you to all of our audience members for joining and listening in. We have a very brief survey that we would like everyone who participated in this webinar to complete. Also, if you have any interest in finding out more about future activities related to the Office for Diversity, Inclusion, and Community Partnership, please take a look at our upcoming events, both on October 20th, more information about the Commonwealth Fund Fellowship in Minority Health Policy, as well as information related to our CHAD mentoring course on mentoring without borders. Again, I want to say thank you to Dr. Clark and Dr. Tsosie for joining us. Amazing presentation. Thank you to Jasmine for organizing this in the background. And thank you to our audience for joining us this afternoon. I wish everyone the best of the day and look forward to seeing you for future equity and social justice discussions. Take care.